Good afternoon, everybody. Welcome to the teaching for the clinical frailty scale. I am Ho Hee Kin, a physician in Hospital Queen Elizabeth I, Kota Kinabalu, Sabah. With me is Dr. Naresh and also Dr. Premala. We will start with Dr. Naresh. Dr. Naresh is a physician in Queen Elizabeth Hospital also. He'll be presenting about the clinical frailty scale training. Without further ado, let's welcome Dr. Naresh. Dr. Naresh.
Thank you, Hikin. Thank you, Dr. Premala and Hikin, for organizing this as well. Greetings, everyone, and welcome to our clinical frailty scale training. So today we want to talk a little bit about the clinical frailty scale, or also known as the CFS. So why is this important? Because at this particular juncture of our time, um, we are all in the advent of the COVID-19 pandemic that's going through everywhere. And the clinical frailty skill training was a tool that is helping physicians in other countries to actually help decide on certain aspects on their day-to-day practice, help to answer questions like, who should we intubate, who should get higher level of care such as ICU care, which patients should go for end of life care. So these are some of the decisions that this clinical frailty scale will help us on our day-to-day practice. So what are some of the learning outcomes? So the first one would be to train the healthcare workers in application of the Rockwood Clinical Frailty Scale. So there are many clinical frailty scales out there, and one of the more established and well-known ones would be the Rockwood Clinical Frailty Scale. Number two would be to utilize the CFS as a decision tool in multidimensional assessment for escalation of care. So here, we really want to emphasize the point on it's a decision tool. So it's a tool to help us decide certain things about a patient. It is not a hard and fast rule that you must use, on everybody, but it's a tool to help us decide. So at the end of the day, our clinical judgment is of the utmost importance. And number three would be to identify at-risk patients early on and help mitigate some of the poor outcomes, and also to lessen the burden towards the healthcare systems. Because as we know, in a time of pandemic such as this, there is a significant burden and strain towards our healthcare system. There are so many patients coming in, so many resources being used, so many manpowers are out there taking care of all the ill patients. And we need something to help us mitigate all our resources. So the first question would be, what is frailty? And I'm sure many of us has heard this word before, frailty. So personally, I like the way Oxford Dictionary defines it. Oxford Dictionary to a layman would define it as frailty or frail is something weak but delicate. I really like they use the word delicate, mainly because it reminds me of a Ming vase. A Ming vase is something that is so nice when you see it, on a table or something like that. But once you tip it over or a stressor, hits it and it falls down, it actually crashes to many pieces. And sometimes frailty in an elderly is something like that. They may be well and good, but when a stressor comes, it affects them quite severely. So we can see that it says here that frailty is a multifaceted, complex clinical syndrome that reduces an individual's resilience. It also leaves them at an increased risk of experiencing adverse health outcomes or even death. So basically, it could be anyone. They can have a spectrum of frailty, as later we will see it will be from 0.1 to 9. And each stressor can affect an individual differently. And the next one would be it's a state of increased vulnerability to stresses due to the age and disease-related deficits that accumulate across multiple domains. So everyone with varying different diseases that they have will have a different degree of frailty, and it's up to us to see what are these diseases and to put them into a whole picture to decide how frail they actually are. So frailty can develop due to multiple factors. So what are some of the factors? It's like socio-demographic influences, for example, poverty, living alone, or even low education level. There are psychological factors, such as depression. There are nutritional issues to address, such as malnutrition. Polypharmacy, there are so many of the elderly who are on so many drugs. And when all these drugs combine, they can cause someone to be frail at times. Diseases and complications of diseases, whether it's inflammatory states, cancer, endocrine disorders, dementias, you name it, most of the diseases would come with a certain degree of frailty. Even low physical activity would cause someone to be frail. What about frailty and aging? So one of the key points we want to highlight here is that frailty is not synonymous with aging, nor is it the inevitable result of aging. So we shouldn't just assume that when we see an 80 or a 90-year-old, coming to our clinic or to the ward that they are automatically frail. By all means, that some of them do actually lead a very fit life. So we need to take that stigma out of our mind. But however, the risk of having frailty does increase with age. So it is more likely that when an individual grows older, frailty would tend to come because of all the many differences, factors that we addressed earlier just now. How about frailty and multimorbidity? So both are distinct health concepts in caring for older adults, though the two are certainly interrelated. So frailty often affects multiple body systems, which can make an individual more susceptible to multimorbidity. So the idea is that if somebody is frail, there is a higher likelihood that they will develop multimorbidity. But on the same time, multimorbidity can lead to increased depletion of an individual's reserve, thereby increasing their risk of frailty. So it works in both ways. So even multimorbidity can cause somebody to be more frail. So frailty is an important geriatric syndrome which is dynamic, which fluctuates over time and reflects multi-system dysfunction. So when you talk about frailty, it's always going to be multi-system involvement, and it fluctuates, meaning that somebody who you see is frail today may not actually be frail, in the next 2 or 3 months once he recovers a little bit, or even vice versa. It's very dynamic. So how do frailty always manifest as? It usually manifests as decreased mobility or even weight loss or decreased muscle strength or even decreased energy levels or decreased activities. Frailty also includes, someone requiring help with their ADLs, such as their household chores, difficulty in climbing stairs, or even feeling a little bit slowed up. So sometimes these are the subtle clues, that somebody who was once able to cook, currently that person is not able to cook, or somebody who once used to be able to sweep the floor or mop the floor, currently they find some difficulty in that. So these are some of the clues that an individual may be having frailty. What about the application in COVID-19? So as older population continues to increase in numbers, so does the admission of older people into the hospital. I'm sure, as we look in our wards, we can see many people who are above the age of 60 there. So acute hospitalization of patients aged 75 or older have increased substantially, and managing these admissions have become increasingly difficult for healthcare systems, especially in the pandemic. And a large proportion of these acute admissions are older people with frailty. So especially now during the COVID-19 times, we see more and more older people coming in to our hospitals. And now we have to decide, about their frailty level so we know how far to go for each of these individuals. So a patient who has frailty is likely to experience a more pronounced deterioration in response to even a minor illness, which will in turn have more recovery time. This decreased resistance to a stressor can result in loss of independence either temporarily or permanently. So if we take a look at the graph on the lower left corner, we can see that there's two lines, a blue line, which represents someone who is a little bit more independent, and a red line, which represents somebody who's a little bit more dependent. We can see that, as the line progresses, the person who's a bit more dependent, or the red line, when the stressor come or the minor illness comes, the line actually dips much more compared to the blue line. And even when in terms of recovery, it actually takes a longer time for recovery compared to the blue line. So this is what frailty is like. Somebody who's a little bit more frail, when a stressor comes, it may affect them a little bit more compared to somebody who's less frail. And when it comes to time of recovery, they may take a longer time to recover, which I'm sure many of us see in the ward, on a day-to-day basis. So what about the effects of frailty? So when frailty is present, there are some poor outcomes like mortality rates. Patients tend to be readmitted a bit more often. Length of hospital stay. I'm sure you notice that those who are more frail tend to stay in the hospital a little longer compared to those who are well. Mortality rates are higher in older adults with frailty than those without. The famous COPE study that came out during these COVID times about COVID-19 in the elderly clearly shows that, those who are more frail, who has a frailty score of 7 to 9, have a higher mortality compared to those who are less frail, having a clinical frailty score of 1 to 2 or even 3 or 4. The discharge to an institution other than home, meaning that those who are frail, sometimes are not able to go home, so they need to be discharged to an institution like an old folks home. Patient reported new disability, so some of these patients have new disability after coming out of the hospital. And increased healthcare utilization. Somebody who is frail, they have an increased level of care, meaning that there's probably more nursing work that needs to be done, or more resources that needs to be used to actually manage them. So what is the CFS, that we've been talking about? So it's actually it's a score created based on the Canadian study of health and aging frailty index. So it's a 9-point global frailty scale based on the clinical evaluation of some of these domains such as mobility, energy, physical activity, and even function. So when is the CFS score used? It usually is used based on the patient's pre-morbid status 2 weeks prior to the assessment, or the presentation of their time of assessment. And this is important. So meaning that we need to get a history of the patient, what they were like 2 weeks before actually coming into the hospital. Because sometimes when they come into the hospital, they are actually more ill than they look. When they are intubated and they are on their venti mask, they tend to look more ill than they actually are. So we need to either get it from the patient, or a collateral history from the caregiver or one of the family members on what they were actually like, 2 weeks prior to this admission. So why the CFS? It's a quick and easy way in a less time consuming compared to other more complex tools which would provide similar information. And it can be used to predict an outcome for the elderly and inpatient mortality, and help target specialty geriatric resources within the hospital. It can be used by any trained healthcare worker to classify the score actually. So anyone, whether it's a houseman or a medical officer or even a nurse, anyone can use this scale to actually come up with where the patient actually is. So what are some of the information that's needed for the CFS? So these are the key factors, which is number one, the overall level of physical fitness. Number two is the presence or absence of any active disease symptoms. The third will be the level of dependency on other people for their activities of daily living. And fourth is the cognitive status of the patient. So especially if we are referring this to the geriatric team, these would be some of the information that they would need to know, before they actually being able to decide, what the patient's CFS score actually is. So a patient's CFS score can also be informed by a variety of sources. So some of the things that can give us information, for example, are like past medical history and comorbidities, medications, social history, physical disabilities or limitations, history of presenting illness, their mobility status and their use of mobility aids, access to formal or informal support, and their cognitive status. So all these are vital informations that we can use to actually determine a person's CFS score. So finally, let's go into the clinical frailty scale itself. So again, we mentioned it's a 9-point scale. So in scale 1 to 4, the key thing that we have to remember is that the patients are usually independent if we are going to score them in scale 1 to 4. So let's take a look at scale 1. Scale 1 is somebody who's very fit. So these are people who are robust, active, energetic, and motivated. They commonly exercise regularly and they are among the fittest for their age. So if you're imagining someone, if this is going to be an elderly who maybe goes up hiking 3 or 4 times a week, or somebody who jogs, very regularly. So these are very fit and well people. And scale 2 would be somebody who is well. So these are people who have no active disease symptoms, but they are less fit than category 1. So often they exercise or are very active occasionally or seasonally. So these are also well people, but the main difference is they are not as fit as those who are in scale 1. Third would be those who are managing well. So these are people whose medical problems are well controlled, but are not regularly active beyond routine walking. So these are probably some of the common group of patients that we may see, sometimes with diabetes or hypertension, who are well controlled, but who already don't really do much activities beyond their routine walking. And next would be group 4, those who are vulnerable. So this group, while they are not dependent on others for daily health, but often the symptoms limit their activities. So the main difference, this would be someone whose activities are already limited in a way. So a common complaint is they actually feel slow. So meaning maybe they can do something, but they're feeling a little bit slower, or they take a little bit more time compared to previous years, or they feel a bit more tired throughout the day. So these are group 4 people. Next, we'll take a look at those who are in scale 5. So these are individuals who are mildly frail. And these people have actually more evidence of slowing, but the key thing that they have is they need help in their higher order IADLs, or instrumental activity of daily livings. So what are some of the examples is they may need help in their finances. Maybe last time they used to be able to buy things on their own or pay things on their own, but now they're having a little bit of trouble. They probably need help with transportation. Maybe they are unable to drive already. They need help with their heavy housework or even taking their medications. So typically, mild frailty progressively impairs shopping and even walking outside alone, or even sometimes things like meal preparation or any other housework. Well, those who are moderately frail, so these are a group of people who actually need help with all outside activities and even with keeping the house. So inside, they often have problems with stairs and need help with bathing and might need minimal assistance with dressing. So as you can see in group 6, even their BADLs are starting to get affected. So they actually need help with, bathing and, even need minimal assistance with their dressing. And most of the outside activities, they are not able to do it on their own already. And in skill 7, we see those who are severely frail. So these are individuals who are completely dependent for personal care from whatever the cause, whether it's physical causes such as a stroke or even cognitive causes such as dementia. But even so, they seem stable and are not at high risk of dying within the next 6 months. So these are actually individuals who their BADL, they are already completely dependent, on their personal care. So we have to be careful in differentiating, between CFS 6 and 7. So why, this is important is if you can see CFS 6 are those who need help with outdoor activities and may need help with some basic activities. Their all-cause mortality is about 6%. Whereas those who are in CFS 7, somebody who is completely dependent for personal care, their all-cause mortality during admission is about 11%, which is almost double. So that's why it's vitally important that we are able to differentiate those who are CFS 6 and 7 especially. Next, we go to CFS 8. So those who are very severely failed. So these individuals are completely dependent and approaching the end of their life already. And typically they can't recover from their minor, even from a minor illness. So these are the individuals that we usually imagine them to be already bed bound, and they're really ill, and we probably need to plan for an end of life care for them already. Well, for those who are in scale 9, those who are terminally ill, these are individuals who are approaching the end of their life. So these categories are mainly for individuals with a life expectancy of less than 6 months, or who are not otherwise evidently frail. So these group of people may look reasonably well on the outside, but probably on the inside they've already have maybe a stage 4 cancer, a terminally ill disease, and their life expectancy is already less than 6 months. So within each level, I know the individuals, it may vary. So about 80% of the people will actually fit to any of the description above. But sometimes, they will fit into two categories, equally well. And if that happens, we actually take the scale that is at the higher or a more dependent level. So if, for example, you have somebody who we are not too sure whether they fit well, in 5 and 6, we take the higher one, which is scale 6. And also, there is some scoring in those with dementia. So the degree of frailty actually corresponds to the degree of dementia. So those who have mild dementia, so what would they have? So some of their symptoms will include forgetting the details of a recent event, though still remembering the event itself, or sometimes they tend to repeat the same question or story, and may have even some social withdrawal. So it may be something as simple as just, forgetting a key, or maybe they went to a birthday party and they just forget one of the individuals who were there talking to them. It's just maybe something really brief, so this is mild dementia. So what about moderate dementia? So these are those whose recent memory is already very impaired, and even though they can seemingly remember their past life events well, they are not able to remember, the recent events so well. So for example, maybe somebody who actually went for an event, maybe a few days ago, they can't remember that event at all. But when you talk about things happening, 20 years ago during their childhood days, they can probably still remember it a little. But even though their recent memory is, very impaired, these individuals are still able to do some personal care, with prompting. Whereas those with severe dementia, they can't really do any of their personal care without help. So next would be how to apply, the CFS. So the CFS can be done by any healthcare professionals who are trained. The information for the CFS can be from the patient itself, the carer, from the home staff, But what we need to know is what was their ability 2 weeks before the current acute illness. And we should not perform the tool based on how the patient appear before you today, because again, we said that that can make the score actually skewed, it's a form of bias. And the decision makers using the CFS, we must check the score to see it's accurate, meaning we must verify the score if you're going to make an important decision based on the CFS score. And, we need to defer the assessment if this information is not available. So why is this important? Even though, at times of this pandemic, that we are going to apply something like the CFS score to make important decision that that involves maybe intubation or even ICU admission or even end of life care. But we must remember that these individuals that we are applying the score to, they are important people. They are people who have probably contributed to the nation. They are people who actually mean something to their family, and they are individuals who are important in their own right. So we must execute proper clinical judgment when making such important decisions based on the CFS score. So what is some of the limitations from the CFS score? So it's a multi-dimensional assessment rather than a screening tool. So it's actually assessment that actually supposed to go hand in hand with the comprehensive geriatric assessment. And it's not really validated for those less than 65 or those with learning disability. And like any decision support tool, is not perfect. So it should be used with clinical decision making. So it's a tool to aid us in our clinical judgment, rather than a hard and fast rule. So applying to the CFS to the patient requires clinical judgment, on part of the examining clinician, and thus may be subjected to inter-observer variation. So sometimes, there will be variation in our clinical judgment, based on the CFS score. And if things like that happen, it would be good to consult somebody a little bit more senior or even a geriatrician about it. So the patient's level of disability heavily weighs the CFS score as well. Next, we'll talk a little bit about bias. So, like any screening tool that is operator dependent on, or something that we need to use a judgment to decide, there is going to be a certain amount of bias involved. So, what are some of the bias that are unknown? Number one would be the leniency effect. So, this is the tendency to be a little bit more forgiving when assigning a rating. So, for example, when we see someone, we want to be a little bit more lenient. So, maybe we give them a lower score of maybe 4 or 5 rather than a 6 or a 7. So the central tendency effect, so this is the inclination for a rater to assign an individual being assessed to a scale that's right in the middle of the scale. So maybe when we see someone, we have the tendency to always put them maybe in a score of 5 or 6, rather than giving them the extremes of 8 or 9, or 1 or 2 or something like that. The halo effect would be the degree to which a rater's overall impression of the individual being assessed can influence their specific rating. And I think this is something we need to be careful of. So meaning that, sometimes we go to the ICU or, to anyone, and we look at the patient, he looks so ill. And that overall impression that we have towards that patient, is the one that causes us to make the bias towards the scale. And that's why it's very important that we need to get proper history on what the patient was like 2 weeks before the acute event itself. And finally is the primacy effect. So this is a tendency to better remember information presented first. So meaning maybe, let's say we have someone where the caregiver actually in the beginning of the history taking, or in the beginning of your interview with him, he actually says that, oh, actually this gentleman was well, he's doing good, he's able to walk, and, he's basically a well individual. But as you dig further, the caretaker actually tells you that maybe this fellow is a little bit more ill. He has some limitations, he has this and that diseases. But when we take the overall picture, we took the earlier part, the primary part, and give the patient a better score than, he actually is supposed to be on. So that's the primacy effect. Next would be the response bias. So a response bias occurs when a person responds to a question with an answer that does not align with their sincere attitude, belief, or behaviors, either intentionally or unintentionally. And the most common type of response bias when completing a CF assessment is actually the recall bias. So, like any other thing, there will be some recall bias, especially when we are taking history from a caregiver or one of the family members. So what are some of the recall bias that we may face? So number one would be the patient and the caregiver's misconception about frailty. Sometimes they see it as a weakness to be dependent on others, and thus they may give some form of bias when taking a history. Number two would be situations where children or caregivers will not contradict an overestimation of function reported by the patient out of cultural respect. So, sometimes because of cultural respect, the caregivers and all that don't really want to contradict the patient themselves, and there may be some form of bias there. And number three would be sometimes the caregivers overly report the frailty due to burnout. And this is a very understandable scenario because sometimes caregivers can get really tired, really burned out from taking care of a dependent patient for a long time. And so because of that tiredness, they may give information that makes it sound like the patient is a bit more ill than he actually is. So these are some of the recall bias that we must be aware of. And so that's are the main things for the theoretical part. So now I pass the time to Dr. Premala to continue with the case scenarios. Thank you very much, and to you, Dr. Premala.
Thank you, Dr. Naresh, for the wonderful presentation. What an insight to frailty, the clinical frailty scale, and also what are the potential things that we need to consider when we are taking the history for the assessment for clinical frailty scale or about the biases. Next, we welcome Dr. Premala geriatrician in Hospital Queen Elizabeth I, Kota Kinabalu, Sabah. She will guide us for a few case scenarios regarding our CFS. Over to you, Dr. Premala.
Thank you, Hikin. Thank you, Naresh. So let's continue with some case scenarios, hoping some stories attached to the tool help us to understand and use the tool a bit better. Concentrate on physical fitness, dependence level, and cognition. Remember that this is a decision tool used in a multi-dimensional assessment, in a comprehensive geriatric assessment usually. And remember also that this tool is to be used and on how the patient was 2 weeks prior to admission and not how they look in front of us today. So for the first case scenario 1, Mr. M, a 74-year-old, he lives with his wife in a double-story house. He is independent in both his basic ADL and instrumental ADL and still continues to drive around town. He pays his bills online, regularly contacts his friends through WhatsApp. His bathroom and bedroom are both upstairs and he's still using them. His asthma is under control with regular Symbicort. Even though he's a bit overweight and doesn't exercise, he's well otherwise. He still does his grocery shopping and attends to Club Pesara Kerajaan once a week just to keep in touch with his retired colleagues. So again, physical fitness, dependence, and cognition. Next slide. So the answer is CFS 3, he's managing well. When we look at his physical fitness, his asthma is well controlled, but he is overweight and does not exercise regularly. He is independent, he has a robust cognition, he's still driving, he's still managing his finances. So the 3 keywords is physical fitness, dependence, and cognition. Let's go on to the next case. So case scenario 2, Mr. Y, 75-year-old gentleman. He has underlying type 2 diabetes mellitus, hypertension, atrial fibrillation with heart failure, and knee OA. Under prior follow-up, he stays in the first floor of a shop lot. He's a retired shopkeeper. He stays with his wife, his son, daughter-in-law, and 2 grandchildren. His usual routine involves mostly staying at home, watching TV, and takes naps before and after lunch. Occasionally, he goes down to the coffee shop nearby and buys 4D number. He used to do this on daily basis, but for the past few months, it's only 1 to 2 times a week. Besides the knee pain, he feels tired most of the time. He feels it's cumbersome to keep going down the stairs. He is independent on his basic ADL, but he doesn't do any of the household chores. His family did not notice any problems with his memory so far, and he's still managing his own medication. So the story will be long. So let's look at physical fitness, dependence, and cognition again. So looking at his physical fitness, dependence, and cognition, he falls into CFS 4, where he is vulnerable. Why? Because he's sedentary, he has active disease symptoms, he's independent only for his basic ADLs, and his cognition is intact. Next slide. So case scenario 3, Mr. M, 81-year-old army man. He has atrial fibrillation, hypertension, and had underwent CABG before. He has lumbar spondylolisthesis that frequently gives him backache. Despite this, he still manages to walk to his farm about 200 meters from home, but he's not able to do any farm work. He has hired a new gardener to maintain the farm. His basic ADL is independent, but he relies on his wife for driving, cooking, and paying bills. Even though he was able to do all of this 2 years ago, he occasionally forgets his medication, so now she has to supervise him. He has a smartphone but only uses it to call out independently, but he's not able to use any of the other features. So, physical fitness, dependence, and cognition. He falls into CFS 5, mildly frail. He's independent in his mobility but limited to his back pain. He cannot undertake any heavy farm work but manages to walk regularly without an aid. He's dependent on his wife for driving, cooking, and paying bills, and also his medication, even though he's independent in his basic ADLs. He manages to use his phone only to call out, but not able to use any other function, and he occasionally forgets his medication. So he falls into mildly frail. The next case scenario is case scenario 4. Mr. A, 66-year-old gentleman, previously worked as a porter in Mount Kinabalu until the age of 50. He developed a left MCA infarct a year ago with residual right-sided hemiparesis. Now he needs one person to assist him in dressing, bathing, and transferring from bed to wheelchair. He has been on Rouse tube since the stroke. His weight and mood has always been good despite the stroke. He can still remember his childhood friends and school days, but frequently forgets his children's name. He keeps repeating his request to go out from the house, and when the family does not fulfill, he gets angry. His son brings him to the park weekly as he enjoys being outdoors. So for this case, he would be in CFS 7, severely frail. The physical fitness because of the neurological deficit, which is permanent, the right hemiparesis and the dysphagia. And that causes him to be dependent in all his basic ADLs. And cognition is moderately impaired, and he also has some BPSD features, though long-term memory is not affected. So by hearing all these scenarios, we may get distracted with all the stories. So remember, physical fitness, dependence, and cognition, that will help us to pick the clinical frailty scale confidently. So these are some top tips to help us use the CFS. This is the tips by the creator itself, Rockwood. And it's all about baseline. We must take a proper history. Whoever who's giving us the information we trust, but we need to verify. And it's only meant for those who are more than 65. Dementia does not limit the use of the CFS. And always look at the changes in the function when you look at CFS. So for further information, there are few areas where we can go through training again. There's also a website or a link that we share later that will give us the case scenarios based on each stage of the CFS. There is also an app available on our phones, the CFS app, where we can easily calculate the CFS. Next slide. Right, so this is the app, and these are our references. Next slide, please. Yeah, these are our references. Hopefully this teaching is beneficial and help us to stratify our patients better. Thank you so much. Thank you, Hikin, and thank you, Naresh.
Thank you, Dr. Premala, for the wonderful 4 case scenarios that we have just now. Just a reminder again, we have other case scenarios for you all to try. We will give you up the link via WhatsApp or via email after this. I hope everyone enjoyed this session, and I would like to thank Dr. Premala, Dr. Naresh again for making this possible for all of us. Thank you, and we'll see you next time.